So good morning, good afternoon, and good evening to all the friends, teachers, and delegates and panelists for today's webinar. I welcome you on behalf of ACNS YNS committee for today's yet another interesting webinar, especially for the whole sole purpose of the education, especially for the young neurosurgeons of low and this medium resource countries, which we conduct on every second and fourth Sunday. So today we have yet another interesting session for which we have Professor Salman Sharif as our chairperson for today's session, who is the chairman of 𝒂𝒏𝒂𝒏 Spine Committee, past president of World Spinal Column Society, chief of neurosurgery at Liaquat National Hospital and Medical College, Karachi, Pakistan. Professor Yoko Kato, who is our chief patron and president of ACNS, who will be joining with us shortly. The discussion for today's session are Professor Alexander Wozniak, who is the president of Ukrainian Society of Neurological Surgeons, and Professor Ahmad Fawad Pirzad, who is the president of Afghanistan Society of Neurosurgeons. Along with me, we have Dr. Ben and Dr. Raja and Dr. Joy Sam and Dr. Atik as the co-moderator for today's session. The two speakers for today's session are Professor Kannan Arnautovic and Professor Dr. Atik Islam. So I would request Professor Salman Sharif to say a few opening comments for today's webinar and also introduce our first expert speaker and some comments about the title of his talk. Professor Salman Sharif.
Thank you, Sachin. I think it's really my pleasure again to join you all in this ACNS YNS webinar. You guys have been doing a great job following it and have attended few, have been part of it. So it's really good fun. I think today's topic is amazing. It's something that we see all the time, and it's a challenge, a lot of challenge, because especially in the developing countries with the financial resources, it could be a problem. But having said that, many people overcome with that. It's really an honor to introduce my dear friend Kenan Artovich, who's from US, from Tennessee. He's professor of neurosurgery there, works in the Baptist Hospital. He has been the really driving force along with WFNS, different committees, and he's really pushed us to our limit. And it's really our pleasure to have him here with us. He's a dear friend and always ready to help and to support. So off you go, Kenan.
Thank you very much, Salman. First of all, let me thank you again. I love the seminars with ACNS YNS, and I really appreciate Professor Yoko Kato, our patron, whom I know for 25 years, always teaching us and being my personal mentor for many years, and then Professor Sharif, good friend for many, many years. Professor Alex Wozniak, my dear friend in difficult times, which I quite understand because I went through that some 30 years ago. Then Professor Pirzad, who is obviously a new friend, and then Professor Islam, Sachin, and Ben. So I'm going to talk about a topic that's dear and near to my heart, and Professor Kato asked me to involve intrinsic and extrinsic tumors. So it'll be a little longer, but I anticipate about 40 minutes roughly. I have nothing to disclose. I'm a volunteer in many neurosurgical organizations, journals, etc., and I do it purely from voluntaristic standpoint. I don't receive any funding for that. It's from my free time and from my own pocket. I just want to tell you that I'm really want to tell you a few words about me, just few slides. I'm originally from Bosnia Herzegovina, from Sarajevo. I was there born and raised, and then after the war, being a neurosurgeon there, I came to do the fellowship in the United States, and then get entangled in a lot of different research and stayed. I grew up in Sudan, and then my kids live in different places, so I consider the world my home. As I said, I'm from Sarajevo, one of the most beautiful cities in the world, host of Olympic Games in 1984. We were in the middle of war, like Professor Wozniak now. We were surrounded for 2.5 years, and I was operating in this hospital, which was completely and directly exposed to artillery. Then my city is pronounced the most beautiful city in the 10 most beautiful cities in the world by this portal. I immigrated to the United States, and this is my city, Memphis. It is mid-south of the United States.
Sorry, Kenan, we can't see your slides. We'd appreciate if you could share your slides, please. And
really?
Professor Kato is here. Hi, Prof. How are you? How's everything?
Please unmute your mic, Professor Kato.
Hi, how are you, everybody? So thank you very much, Salman. So long time no see. Maybe we can see in sometimes.
Sure.
Now we can see the slides, Professor Kanna.
All right, so I will then briefly restart. You can see my slides, right?
Yes.
Yes.
Okay. So as I said, I am a volunteer in many neurosurgical organizations, and I told you that coming from Bosnia and Herzegovina and being citizen of the world, I told you my home city, and then obviously operating neurosurgery in the middle of the war, like some of our colleagues today. And I said that I live now in Tennessee, in Memphis, Tennessee, where I'm in the past 20 years. This is where I live, mid-south United States. My city is called the City of Three Kings, Martin Luther King, Elvis the King, and B.B. King. It is home of the blues and birthplace of rock and roll. Many people from American pop culture and live there. My university, where I'm attending, is 226 years old, and medical school 170 years old. They say in America everything is very new. Well, it's pretty long tenure. So this is our current faculty. St. Murphy Clinic has given 8 out of 87 presidents of ACNS, and I learn leadership everywhere every day from my senior partners. So primary spinal tumors are rare. Only 15% of primary CNS tumors are spinal. And as you can see, slightly more extradural than intradural. Extradural mostly malignant metastasis. Intradural are split between 40% extramedullary and then 5% intramedullary. And this is the split. If you look, most commonly there are schwannomas, approximately 1/3, meningiomas 1/4. Interestingly, schwannomas most common in lumbar, meningiomas most common in thoracic. Then you have gliomas split between astrocytomas and ependymomas. Then metastasis 5% usually come from lung. And then 30% of them have simultaneous brain mets, and then miscellaneous other tumors. Clinical features, as you know, consist of myelopathy and radiculopathy. And somebody has calculated approximately 2 years patient starts complaining about symptoms, and then he or she gets diagnosed. Usually there is gait disturbance, spasticity, if it's upper spinal cord, bladder bowel incontinence, or retention. Nocturnal pain is very common. This is the articles that I published before. Now the numbers are doubled in quantity, so I have pretty robust spinal cord tumor practice. This is the book that I published about 3 years ago with Dr. Gokaslan, and it has become one of the best sellers of Springer, and they are preparing a new edition, and I'm very proud of that. One of the things that I want to mention to my younger colleagues, what is the most important thing in operating these tumors? Well, I spent a lot of time in the lab, in anatomy lab, about 2 years. I dissected all parts of the central nervous system. So microsurgical anatomy is the key. Microsurgical technique, and then understanding the disease, understanding where to go, when to go, how to operate is very important. So if you forget everything that I tell you today, and just remember this, that for every case in the spine before surgery, I harvest a piece of fat, which I put in epidural space, and then obliterate the dead space where we did laminectomy. And I'm still waiting. After a few cases that I had at the very beginning of my career, spinal fluid leak. I'm still waiting for the first spinal fluid leak or pseudomeningocele since I've been utilizing this technique. So some generative operative consideration. I do steroid bolus. I always monitor with SSCPMAP D waves, of course, antibiotics. If it's lower spine, thoracic lumbar, we use Jackson carbon operative table because they are transparent for AP X-raying. And then I like to expose rostral caudal margins with laminectomy, hemilaminectomy, laminoplasty in children. And then if we are in transitional areas of the spine, cervicothoracic, thoracolumbar, we do use instrumentation, of course. We divide dentate ligaments as needed. And once we do that, we can rotate the spinal cord a little bit. And then intraoperative ultrasound is always used. So I'll give you some samples. This is a professor of stomatology, dentist medical school, came from all the way from Sarajevo for me to operate. You can see this fairly large tumor, which is dumbbell shape. And by the way, all of this, or almost all of these articles, have been published in Operative Neurosurgery or World Neurosurgery. So I put here just some reference for if younger colleagues want to find them and go into more details. But you can see here on this slide here in the middle low that there is very, very close associations with vertebral artery. And then there is obviously some perforators contributing to this tumor. So I'll just go through this video clip. So this is the position, prone position, as I said, cervical spine, we put in tongues. And this is now opening of the dura after exposure. You can see here, there is elevation of the arachnoid membrane, and then we are dividing dentate ligament. We always do that because it's tremendous. This small ligament, once we divide it, it gives you tremendous mobility. And you can see here the tumor, how it's already relaxed. This is a perforator from the vertebral artery. This is pica, 11th nerve. And you can see here, first thing, we need to connect the intradural and extradural part by opening the dura here in the isthmus area. And there is a lot of bleeding from plexus, epidural plexus. And then we started debulking the tumor within the neural foramen here. You can see it. And then after that, after we debulked the tumor and decreased the pressure on it, we divided the C2 nerve root because it was completely invested by the tumor, as you can see here. This was a C1 nerve root. And then after that, tumor comes to the surface. As you can see here, we protected the spinal cord, and we do not here touch the any of the neural elements. As you know, C1, C2 nerve roots do not have, other than sensory function, do not have any significant motor function. So here we come now to the tumor. And here you see, we noticed at the beginning of surgery, this perforator coming to the tumor. So we knew about it, we coagulated it, we emptied it, took it out, and basically we complete now the removal of the tumor in the foramen. You see big expansion here using CUSA. And then at the end, this closure is very important. As I said, you first close the dura what you can do with direct sutures, then you use the patch graft, and then at the end of surgery, you put fat tissue that you incorporate in the suture. And basically, this is the end. You can see here the patient, you can see here gross total resection, obviously doing well. She went back and she's operating now. She's a surgeon, a professor of dentistry. Another case, this is a spinal cord tumor in the left neural foramen of C6, C7, I believe, 2, 3, 4, 5, yeah, C6, C7. This is opening of the dura now. This is, remember, other side. This will be the left side, the other one was the right side. And you can see here again, opening the dura in the form of letter T. This is basically exposing. Now here, unlike the other case, we have to preserve all the neural elements because, as you know, C6, C7 nerve is very important. Here is now opening the tumor in the foramen. So you have completely exposed tumor. And now, like any schwannoma, you open it in the middle and then start debulking it. So you basically decrease the pressure within it and remove it. You have to debulk it, but of course, dissect from any surrounding soft tissues and control the bleeding, because you don't want any bleeding. I'm allergic to see blood in my operative field, and whenever I can help it, I have always absolutely clean field. So anyway, this is now resection of the tumor, debulking it from inside, surrounding it here, and you notice how I'm trying to, while debulking, to protect the ventral part as I'm coming down onto the ventral and dorsal nerve roots. Final part of surgery, and you can see now the tumor is practically almost completely removed. Here is the last part of it coming out. You can see that now the nerve here completely preserved, hemostasis. Gel foam powder is unbelievably important for hemostasis in the spine. I use gel foam powder balls, and here is the closure, same as last time as I showed you. Again, don't forget, you will never see CSF leak if you use this technique, at least according to my modest experience. This is preoperative and postoperative scan. And this is a last schwannoma that I will show. This is the giant schwannoma of the lumbar, thoracolumbar spine. It is T11, T12 lower thoracic spine. I published it in BGBMS. This is a position of the patient. I just want to show you this utilization of AP fluoroscopy. And this is basically the resection of the tumor. I will advance to the crucial points, monitoring SSCP, MEP, and T waves. Here is opening of the dura at the lower aspect. I try to stay above L1 here for laminectomy to avoid crossing the thoracolumbar junction. Opening of the dura. I like this pot scissors. And then arachnoid, as Professor Yashagil has taught us, see how I use Liga clips to put the arachnoid membrane adjacent to the dura, and then I'm here seeing the tumor. First, you see nothing; it's all tumor, and remember, you are at cauda equina area, so you want to be very careful and preserve all the nerves. And here, first thing, what we do, we'll open this capsule and start removing the tumor. First, sending few pieces for histology, and then starting to dissect and protect the nerves with this with patties. I like if I can avoid seeing and compressing any neural tissue. I like to protect it early, and then here you can see now debulking of the tumor. So as we progress with our CUSA debulking the tumor, you can start seeing the nerves that are pushed laterally and ventrally. And here you can see I'm coming right there to the cauda equina nerves, and I'm leaving that to the end. I'm trying to do more of the debulking, as you can see here, progress closer to the cauda equina. And then here, as you can see, I identify the nerve root of origin. I'm preserving it. Here are all the cauda equina nerves on the right side, and then finalizing the tumor resection. Here's the tumor coming out. There was one nerve that was going straight to the tumor sensory nerve. You can see here we identified it, we tested it with stimulation, and then we resected it. Here is removal of the tumor completely, and then the picture of the cauda equina. as you can see here, completely preserved. And then at the end, we bring back the arachnoid membrane the best we can, close the dura the same way as we always do. This is just to show you utilization of ultrasound. This is before surgery. You can see the tumor here. And then you can see the spinal cord up north. And then now after surgery, you see the removal of the tumor, how intraoperative ultrasound can help you intraoperatively in real time decide about radicality of tumor resection. You can see here nicely the nerves and the resection of the tumor. This is a postoperative patient. You can see her here. She had significant gait problems, but she recovered it completely. And this is postoperative gross total resection. Another schwannoma that was presented with scalloping of the sacrum. You can see here it's dumbbell, and sacrum doesn't have a lot of muscles on the top. So this is a particular area where you need to be careful with tumor resection and postoperative CSF leak. And of course, very important to pay attention to 𝒂𝒏𝒂𝒏 nerves down there, because you can easily get bowel bladder problems if you are not careful and don't use monitoring. Spinal hemangioma, technically it's extradural tumor, but it goes in and out. So I included it. I also published this one, and I'll show you. It is very vascular tumor, and we knew from the beginning it's going to be vascular. And as I said here before, I like to keep my tumors completely avascular and non-bleeding, despite this very, very rich blood vessels. You can see here how we are dissecting the tumor from the dura and progressing towards the foramen. And by the way, this tumor was staged. I did intraspinal canal resection, and then thoracic surgeon came and did transthoracic approach to remove it from the thoracic cavity. But anyway, again, protection of the dura, decompression of the tumor, and what's very important, going ventrally to preserve the nerve root. Here we are coming to the ventral part, dissecting now the tumor of the dura, and then completing the resection. Very, very useful to use the gel foam powder in these resections. And here you can see the tumor is almost dead now, and taking it off the nerve root. As you know, in thoracic spine, the nerve roots are mostly sensory function. They have motor function, but for small intercostal nerves. So once we divide the nerve, we have to ligate to avoid CSF leak, and then basically this tumor invading the nerve is now freed up for gross total resection. This is now ventral part of the spinal canal and going to the thoracic cavity. And as you can see here, final stages of resection. I use diamond drill to open the foramen with irrigation. I use diamond rig. It's one of my favorite tools. I use it for dissection, and I use it for resection of the tumor in the bone. So we need to master the use of drills in these surgeries. This is a patient postoperatively, and this is him walking. Ependymomas are a different story. This is a patient that presented almost quadriplegic. He waited a long time. He was scared to see the doctor. And then eventually when he stopped moving, came to us. You see here, this is more of a medulla oblongata tumor, but there is a little component in the spinal cord, and then most of the tumor in medulla oblongata. I did publish it, as I said, and I'll show it main tumor stages. So you can see a big cyst, and this is exposed. You can see the tonsils. You can see the bulky medulla. And first, what I like to do, always wide exposure. I want to see my vertebral arteries. I want to see my picas. And then I want to see central median sulcus, which I'm opening here, right in the midline between the sensory columns at the dorsum of the spinal cord. And once I expose and open both proximally and distally, I'm happy and content that I can start debulking the tumor. But as you can see here, we don't touch the columns. We go straight in the midline, and that way we are able to expose the tumor both proximally and distally. So here is the exposure of the distal part of the tumor, exposure of the caudal part, and here you can see gentle retraction of the dorsal columns and distal part of the tumor. So I know now proximal and distal part, and now I'm starting to develop the, you see this pseudocapsule, very important. We learned that from our teachers, and you see how there is nice plane where you can not even violate any of the neural tissue, and then resect it with scissors or CUSA, first debulking and then completing the resection. So debulking proceeds. I'm getting less tension, as you can see here, developing the plane, helping with small micropatties, and this Yashargil bipolars with protection at the top are very, very important because they avoid any sharp violation of neural tissue. Here is the end of the surgery. You can see now here we're coming to the ventral part, still some lateral part of the tumor, and then here is you see a lot of my patties here. Here is a resection of the most important part of the tumor here, and then final part of the tumor, the most caudal one. And after the storm, after this terrible situation and not knowing where is what, at the end of the case, the storm is over, the sun starts shining, and you can see intact spinal cord, medulla, and basically beautiful postoperative picture. Patient who was previously quadriplegic came for suture removal, and you can see him here walking. I'm now monitoring him for a few years, and he is neurologically intact, back and working. Myxopapillary ependymoma is completely different than ependymoma, and you see here they usually live at the area of L2 and the phylum terminale area. The trick in these tumors, like in any other spinal tumors, is to expose proximally and distally. Again, if you dissect the arachnoid membrane and tent it to the dura, you really start getting a good feeling of proximal and distal, as well as lateral tumor anatomy, and that really helps you more meticulously dissect the tumor. So you can see the tumor here. We are now coagulating the phylum proximally and distally, and I like to allow ample room to avoid any tumor being involved there, and of course pathology check it. And you can see here dividing the phylum. Here proximally also you can see very thick phylum. We tested it and stimulated it. There are blood vessels in it, so be careful. If you cut it, it can kind of cause intraarachnoid, intradural bleeding. So I like to coagulate it as high as possible and then divide it. And here is the gross total resection. Again, I'm not happy, obviously, here, and I'm going to dissect a little bit more of the proximal phylum terminale and resect it just to make sure we don't have any further residual tumor. Because although they are grade 1, they have some tendency of recurrence. In my series of about 15, 20 cases, I'm still waiting for the first recurrence, and you have to have a long-term follow-up with them. At the end, I want to warn you, it's important to remove all the blood and the coagulums from the nerves, because they cause arachnoiditis, and that can cause some pain postoperatively, so we have to be careful. Here is gross total resection and comparison pre-op and post-op. Meningiomas are quite different. They may come in cervical, thoracic, and lumbar area. This is one sample of high cervical adjacent to the vertebral artery. You can see here a hint that this is very calcified. And here, this tiny little thing is spinal cord, completely pushed by the tumor. And one of the important things is to dissect, as I showed in the previous slide, proximally vertebral artery and pica here, distally, and then detach the tumor origin. Here is postoperative picture, gross total resection. This is pharmacist from Memphis. She's just graduated pharmacy school. She had inability to walk, bowel, bladder incontinence. And very interestingly, you know, when I saw this tumor, I thought it's schwannoma because it's dumbbell, but be careful, because about 5% of meningiomas may also be dumbbell. And as I showed this hemangioma before, it was dumbbell. So dumbbell does not mean necessarily schwannoma all the time. So be careful when you plan surgery. And this is postoperative pictures. I did fuse the other side of the facet here, as you can see, because I had to do fascicectomy. So I wanted to stabilize her spine and not think about problems there. This is the gentleman. I published this case in World Neurosurgery. He had a retropharyngeal abscess first and previous history of Hodgkin with irradiation of his thyroid cancer and Hodgkin, both diseases. He presented with hyperreflexia. And this is, I here explained my original dural splitting resection. I'll show you in a minute what I mean by that. Here is the exposure. This is, again, I like to elevate the dura. I teach my residents in cranial and spine and skull base. I like to elevate it with dural stitches and then pull it up. I don't want any potential violation of neural tissue. Dura can sometimes be very vascular. And I use Penelope's. This is my special dear instrument that my mentor gave to me when I graduated. I still keep them. And I protect the arachnoid by using this instrument. It's like a dental tool. I also use sometimes pot scissors. So these are the two techniques I use at opening. So here is the eventually exposure of the tumor, and this is calcified dura, and this is the tumor, and here is the attachment of the tumor to the dura. So as you can see here, I'm first dissecting the tumor from the spinal cord that's terribly compressed. But by opening the dura and reflecting it laterally, I gain space now where I can push the tumor. And here you can see how gently we are dissecting it off the spinal cord. This is, remember, C6 level. Here is part of the tumor that is involved by the dura. And here I'm dissecting from the arachnoid membrane, devascularizing the origin of the tumor from proximal to distal slowly. It's my resident working now. He's doing a beautiful job. He became later one of our partners, very talented. Happy to have him. And this is finalization. You may ask yourself why I didn't use KUSA, because the tumor was very calcified and I felt I have enough space here and I'm not violating the spinal cord. Note here how we are having now good exposure and basically tumor completely dissected from the. Here is the nerve, of course, we have to preserve it. You can see it here. And then coming back to the origin of the tumor to complete resection. Now, this is this dural. You can see here preserved nerves, spinal cord untouched, but to avoid CSF leak and difficulties closure, we invented this technique called dural splitting technique, where we split the normal dura and dura infested by the tumor. And you can see here, splitting the dura that's very thickened in this area, we produce gross total resection, but at the same time, we still keep a layer of the dura, because as you may imagine, doing watertight closure in this area would be near to impossible. But here we achieve gross total resection with this splitting the dura into dura diseased by the tumor and a normal dura. At the end of surgery, you can see here we have glistening dura that has no tumor in it. Again, my technique of fat tissue that provides prevention of CSF leak or pseudomeningocele, and this is the end of it. This is a patient after surgery, gross total resection. And one thing I want to tell you before we go any further is that our resections are very good, but if you get complications, then it becomes very, very problematic. And therefore, you have to present CSF leak. I'll move on. I'm now about 30 minutes. We had a little delay in start, so I have about 3 or 4 more cases. But this is thoracic spine, again, meningioma. This is how we determine extension of the tumor on AP X-rays. And you can see here postoperative scan. Hemangioblastomas, again, published in neurosurgery. Let me just go back. Just to show you, here is the tumor, here is the nodule in the brainstem, here is the cyst and extending into the spinal cord. And then just a trick in this I want to show you. This is the nodule of the hemangioblastoma. This is the main draining vein. You do not address the main draining vein until you completely devascularize the tumor from the pia and dissect it and take it off. There is a perforator here. You cannot violate it, so therefore you work around it. And you can see here in a moment, my resident is going to retract this perforator so I can go between the perforator and the tumor. Fast advancement. Coming around in the lower pole, you can see here C2 nerve root, coagulating, devascularizing, coming around. And then only at the end, we come to the vein, coagulate the vein, and then the end, and remove this nodule. And here is the final stage of surgery with the removal of the nodule. And it's out. You can see here pica. You can see the cyst previous. And one of the main complaints of this patient was inability to swallow. Next morning of surgery, I was so confident of decompression that I offered her some meat, and she's here swallowing. My speech pathologists were upset that I did a swallowing evaluation of my own, but here is the result. Another case, a thoracic hemangioblastoma. I'll go to the money. Here is the cauda equina nerves. Here is the plane between the hemangioblastoma and the nerves. We release the tumor laterally. It's like a big AVM. You don't go inside, God forbid, because you can have intractable bleeding. You need to know your strategy and how to remove this tumor. Otherwise, you may have disaster from a beautiful surgery. Here is the release of proximal part of the tumor. Here is a dissection from the lateral aspect of it. And remember, this main draining vein you can see here in the center, I preserve it till the very end, and then basically remove the tumor. Here is removing some of the coagulums. And you can see here we are getting to the ventral part of the tumor. It's clearly visible, the nodule of it. Here is the nodule coming to the surface. And then we are coming to the vein that we preserved till the very end here. Here is that vein. And now still vein is preserved till the very, very end. And here is the removal. This is the patient postoperatively. You can see here that the syrinx you see this is a nodule before surgery with the cyst, and then syrinx all the way to cervical spine. You can see that syrinx collapsed, and he's a plumber, and he had a gross total resection, intact neurologically. His urinary retention resolved. A low-grade astrocytoma, I also published this one. I'll just show you one of them. I have two, but I'll show you one for the interest of time. This is her preoperative gait. And this is the tumor. You see here expansion of the spinal cord. This is a T2 area, very sensitive for surgery. Here is the tumor, as I can show you here. And then again, the same opening. We're not going to lose time on this. I like to find my central sulcus, posterior midline myelotomy, as I said before. Here is, we are getting into the tumor area. I want to expose proximally and distally and use ultrasound for this. You have to coagulate these blood vessels at the surface. There are always few veins, but you stay largely between them if you can help it. You can see here the tumor. I'm just trying to expose it distally here, but you can see proximally the tumor. One of the things, note here, I do, as I split the Iranian membrane, when I split the spinal cord, I use proline, and you can see how I open the PIA like a book here. So that allows me resection of this tumor and dissection in a longitudinal, not lateral fashion. Here is resection of the tumor. You can see discoloration, obviously, and astrocytomas do not have a good plane, so therefore you need to sometimes work with the sharp dissection, sometimes with the CUSA, but you have to be very careful because, as I said, they don't have a good plane as the ependymomas. Here is final stages of tumor resection. Not very big tumor, about 1 centimeter in size. Here cleaning the last remnants of the tumor. Cell by cell. You have to go cell by cell with astrocytomas closure. And you can see here gross total resection. But look at this. This was gate preoperatively, as I showed you at the beginning. This is gate now. And another case, I watched this one, 2006, she presented with this small tumor, again, T2 area. I didn't want to operate. I waited. 2011, no, not much change, but 2015, significant increase in size. She started developing bowel incontinence. I'm going to skip this slide, but this is her gross total resection, and you can see her gait postoperatively. Another astrocytoma. For some reason, I get astrocytomas only in T1, T2 areas, and that is kind of a very sensitive transitional vascular area. So again, pre-op and post-op and post-operative picture of the patient. Another case of astrocytoma. This was anaplastic. She had radiation after in the cauda equina area. You can see her here with me post-operatively, and the gross total resection. Final case, and I will close here. Keep you right at 40 minutes. So Professor Kato does not get upset with me. This is metastasis of the lung cancer. I published this in operative neurosurgery as well. This is here, C5, C6 level. Usually C5 mostly. You can see it's off to the left side. And this is tumor resection. Patient had left hand weakness and some gait disturbance. So this is opening of the arachnoid membrane. As I mentioned before, very important in resection of the tumor. You can see the hint of the metastasis here coming to the surface. There is a raphe in the middle between the arachnoid membrane and the pia. So you see, you have to dissect it, and then you start getting onto the metastasis. This is one of the cases where you don't do central myelotomy, but you do resection. If it comes to the surface, you do resection where it comes to the surface. So this is tumor involving the nerve. So we had to take this nerve because obviously it's completely involved by the tumor. And then this is the second part of the nerve that's involved by the tumor. I had to do this first to be able to mobilize the spinal cord and to be able to, this is dorsal nerve root of C4, as you can see here, involved by the tumor. If we have to sacrifice the nerve due to the involvement by the tumor, you have really to be careful and avoid. And here is important point. You see, this is your dentate ligament. Here, by cutting the dentate ligament, you will see how much space you will gain and how spinal cord becomes much softer and less tension. And now we are coming around the tumor, creating the cleavage in a slow processing fashion. Here is a clear plane between the tumor that's now avascular and the spinal cord. And here is metastasis coming out in one piece. Monitoring really helps, and it's important to have it, and you react to your assistant's warnings, obviously by stopping dissection if they see declining the amplitude of the waves, and also irrigating, adding some steroids and so forth. I'm now inspecting here the cavity, making, oh, sorry. Here is the final picture. You see very nice glistening spinal cord. And then again, my traditional fat. Postoperatively gross total resection. So in conclusion, I want to tell you that this is, I like to do mainly skull-based surgery, tumor surgery, spinal cord tumor surgery, pituitaries. I like also to do some general neurosurgery. But this is one of my most favorite parts in neurosurgery, because we can resect these tumors radically without any mortality and almost without any new morbidity. If you do thorough preoperative planning and good microsurgical technique, do early rehabilitation, avoid CSF leak, which can bring them down for another week with lumbar drain, get them out early, you will prevent any significant morbidity such as PEs, pneumonia, and all that. So CSF and pseudomeningocele is part of the past in my mind, in my hands, and patient, as I said, tend to completely recover their neurological function in most cases after surgery with rehabilitation, even if they have a long-standing preoperative deficit. And age is not limit. I have patients, as I showed you, the lady with meningioma, 84, 5 years old. I have very young patients throughout the course. Thank you very much. I kept you at 45 minutes, and I hope that you'll have some questions for me.
I think wonderful talk. Really enjoyed it. Every piece of it, and tips regarding for young neurosurgeons are amazing. And looking forward to seeing you and learning loads from you in future as well. There's only one question in the chat at the moment, and the question is, with astrocytomas, when you take them out, do you send them for radiotherapy afterwards?
That question depends on the type of astrocytoma. Of course, as you know, astrocytomas can come in all shapes and sizes and histological. You can have grade 1, grade 2, 3, and 4. And I showed you grade 1, and I showed you grade 2, and I showed you grade 3. Grade 3 went to radiation. You have to radiate them because there is a moment when they get aggressive, malignant, and you have to prevent the seeding. But grade 1 and 2, if I have a good feeling of resection, I don't radiate them, and I wait until I see anything suspicious. And of course, these tumors are lifelong following. You have to follow them for life because almost all of them can come back.
Okay, brilliant. Atiq Islam has a question. Please go ahead. Please unmute yourself.
Thank you. Thank you, Professor, for your nice presentation. Basically, it is a good learning for the young neurosurgeon like us. Two simple questions. During mid-dorsal lesion, do you suggest any preoperative marking X-ray, or you do level perioperatively by using CM? And second question is, sometimes in case of large intermedullary tumor, dorsal midline raphe is sometimes obliterated, and perioperatively it is difficult to find out the dorsal median sulcus. So what is your tips for the YNS in this type of cases? Thank you.
Thank you, Dr. Islam. First of all, in my strategy, I like to expose, as I showed you, proximally and distally. I like to know the extent of the tumor, and for that, ultrasound is very helpful. Also, AP X-rays, but when you come to the tumor, ultrasound will detect you exactly if you have enough exposure. So I try to keep the bone to the edge and don't go more than I have to with laminectomy. Now, of course, as I mentioned at the beginning, if it's transitional area, we do fusion, or we can do laminoplasty, which I do as well sometimes. So once we get the tumor, if the spinal cord is completely swollen, and you really cannot know for sure where is the midline sulcus. As I showed you in some of those videos, I expose laterally, and I see my nerves laterally, and I know exactly the width of the spinal cord. And then under the highest magnification, I determine what I believe is the midline sulcus. And the other thing that will lead you is orientation of blood vessels. There are blood vessels on the surface, and they tend to respect right side and left side and leave you a little gap between. So that's another hint that you have where is the midline sulcus. And then once you open the pia with the sharp knife, 11 blade, and once you tent it with as I showed you with proline to the side, like open the book, then you see kind of orientation of the fibers, and you can hint the little gap between the right and left column. So I don't know whether how sophisticated is this method, but watching, touching, kind of measuring the width, seeing the orientation of blood vessel can help you find it.
Okay, thank you. Thank you. I got your point.
If I may ask one question, Professor
Yes,
Sharif?
sir.
Please go ahead.
Well, thank you. Thank you very much, Professor Ken and Arnautovic, for this wonderful lecture. One simple question is that I saw that you took out a facet in the cervical region and you fixed it. So what is the philosophy in a case of lumbar dumbbell neurofibroma where you have to take out a facet, and whether you fix it or not? I'm asking this question because earlier we had Professor Nicolae Convolou from Burdenko who presented here, and routinely they never fix in spite of taking 1 or 2 level facets. More than 3,000 cases they have shared their experience. So what is your philosophy in here?
Well, I go with the philosophy of spine, and Professor Sharif is an expert here. there are 3 columns in the spine, okay? And if you violate the 2 columns, the spine by definition becomes unstable. And then if you also, if you violate the column completely, it's one story. If you violate the column partially, it's another story. So it all depends about the extension of resection of the facet. Now, if you have, for example, the supraspinal ligament, interspinous ligament, and other facet and lamina intact, obviously you don't have to fuse. But if you have to remove the other side as well, and also you have to look, is it a younger person, is it muscular patient, you have to do flexion extension x-rays. So it's not old system, one size fits all. You need to judge by the age of the patient, by the pictures, by flexion extension x-rays, by plan how much facet and how many facets you are going to take down. You're going to take down the disc, you're going to take down the ribs, but lumbar spine usually need to be very careful. And doing fusion, we are neurosurgeons. I trained, like you all guys, I trained from my first year in the United States when I was starting my second residency, putting fusion. So I can put, I'm a skull-based surgeon, but I can put screw wherever I want, because I learned. For us, it's easy. So it's not a matter, do we know how to do it? It's a matter, do we need to do it? And of course, if we don't have to use it, we don't use it, but we shouldn't fear of spine. Our teacher generation has taught us the spine belongs to neurosurgery. And by the way, I have 3 of my partners who do only scoliosis. I hope Salman is going to visit us one day. Sure. 3 young partners doing only scoliosis. They don't do anything else in neurosurgery, and that's all what they do: scoliosis, kyphosis, deformities. So spine belongs to us. Instrumentation belongs to neurosurgery. We need to learn it. We need to master it. When to fuse it, how to fuse it, and so forth.
Thank you.
I think brilliant. Joe Sam, you wanted to say something?
Hi, thank you very much.
Joe?
Prof, there was an excellent talk. I actually have three questions. First, very burning question for myself is, let's say if you have a motor root schwannoma and intraoperatively you have tested and it is definitely attached to a motor root, how do you maximize, or when do you stop resecting the schwannoma if you cannot remove it completely? There's no clear capsule or claim. Second question, when and where do you take the fat graft from? Before operation, after operation? And thirdly, expanding on Atik's question, would you suggest any type of neuro monitoring, or think that it's not necessary when we want to operate for intramedullary tumors? Thank you very much.
Dr. Sam, thank you for your questions. All very good questions. Motor schwannoma by definition, most of the times belong to sensory nerves, which is good for us, good for the patient. Sometimes they belong to the motor nerves, very rarely, at least in my practice. What I would do with them is, it all depends on many, many different factors. How old is the patient? What does the patient do? Do they play piano for a living? Do they, so the size of the tumor, how much preoperative neurological deficit. So I guess your question is, should we sacrifice the motor nerve involved by schwannoma? It has to be a very judicial decision in my mind. When is it time to do it, and when we should abstain and leave the piece of tumor there to avoid a deficit. So using intraoperative stimulation helps some judgment about a neurological deficit preoperatively. Another factor in your decision making: age of patient, size of tumor. So these are all the things in decision. The second question you asked me about fat graft, I usually take it when a patient is positioned before we turn the patient prone. I just make a small incision about 1 inch, 2 centimeters on the side, and then open with the Bowick outer. You take a piece of fat size of the golf ball, and out of many, many thousands of patients that I took the fat graft, I did have 1 or 2 patients that developed hematoma there. So it is the only complication I have seen, and happened maybe 0.1% or 1%, less than 1% of my cases. But I always take it at the beginning of surgery. And, you know, one time that you get CSF leak, one time that you get patient for a week with lumbar drain, and then he or she develop pneumonia, and they develop blood clots in legs and pulmonary embolus, you'll regret your life with that patient. And the wonderful surgery took the tumor out, intact patient, neurological deficit gone, and all that. Monitoring, as I said, I have a good crew with monitoring. I have excellent technicians. They are mostly technicians. The doctors, neurology, are on the computer somewhere watching so technicians are usually with me. They are so experienced. I trust them 100%. They know what they are doing. They do it every day or every week. So that's the way the way I do it. D-Wave is also very important.
Yeah, D-Wave.
As I said, I'm just preparing one article about the importance of D-Waves in preservation of neurological function. One of my residents is working. I hope this answers your question.
Okay,
Yes,
brilliant.
yes.
We will move on to Ben. Can you keep it short because we're running short of time? Thank you.
Yes, I'll keep my question short. So thank you so much, Professor Tan, for your lecture. It's very educational, and congratulations to your result. I have 2 very short questions. The first question is a follow-up question from Dr. 𝒁𝒏𝒂𝒏. So it's very important to make sure the correct level, especially in, for example, the mid-thoracic tumor. So any tips for young neurosurgeon in using X-ray C-arm for the correct level for the identification? My second question is about any experience with a pediatric intrinsic tumor. So how would, in case you need a long segment laminectomy, how would you manage the potential instability? Thank you so much.
Let me ask second question first. I do adult neurosurgery. We have 5 of my partners, Dr. Boop, who just retired, and some other good friends. They are pediatrics, so I did operate few cases with them. My patient population is mostly adult, but I would always use in kids laminoplasty, where you will remove the laminas and then return them back. I personally return them. Synthes has also nice screws for laminoplasty. You can also use Medtronic, or you can use the cranial plates are also very, very functional. They're nice plates that you can use with 4 or 5 millimeter screws that are perfect for the thickness of lamina. The first question, remind me the first question.
It's about any tips for the young neurosurgeon.
AP X-ray, yeah. So AP X-ray is very important. Thank you for this question. Very important. I teach my residents how to orientate on AP X-rays. So there are 3 areas where rib goes to the vertebrae. That is T1, T11, and T12. Okay. All others, the rib goes to intervertebral space where it attaches both to the superior and inferior vertebrae. So when you calculate, it's very easy to decide which level is it, because lateral in the thoracic spine doesn't work. I mean, if you start counting from sacrum up, you will never do it, and you lose the counting, and it's messy. AP, it's 1 minute, shoot an X-ray. I drape the top part with I call it the shower cap, you know, the clear covering, and then I basically move it out, and then if I need to put it in, so I use combination of AP X-rays in the thoracic spine and ultrasound, always on the table.
Thank you so much.
Okay, move on to the next question. I think let's keep it the last question. Dr. Akachu, would you like to ask the question, please? Please unmute yourself. Thanks. Sorry, can't hear you. I'm
We
sorry,
can't
we
hear you.
can't
Can
hear.
you unmute the button?
He's unmuted, but we can't hear him.
Can you hear
Can
me
you
now?
please type your question?
Okay, okay.
Now we can hear you. Can you speak loudly? Maybe we can hear you.
Okay.
Try to
Can you hear me now?
Yes.
Can you
a
hear me?
little. If you, yeah, I think
Oh.
so.
Speak loud. I think I can hear.
Okay, sir. Okay, sir. Sir, thank you so much for this presentation. I'm curious. So, how do you use? You made us know that fat graphs have helped you to prevent CSF leak in the course of your surgery. Fat graphs in your surgery. So, how do you place this fat graph? You incorporate it after repairing the dura, or you incorporate it while repairing the dura? Thank you so much, sir.
Yeah, excellent question, and thank you. This completes this helped me explain it more. So I always close running suture, fully close 𝒕𝒓𝒏𝒂𝒏 maneuver. The problem, Dr. Aniaku, is the fact when you release the CSF from intradural compartment, even with Valsalva maneuver, you cannot mimic the pressure which is before releasing of CSF intradurally. That is why it's not reliable, because it can, when the pressure builds up again, it can start leaking somewhere. So once I finish my closure, all the suspicious areas, I do additional stitch and include the fat small piece. I just cut a small piece of fat graft there. When I finish all that, I fill the gap remained after laminectomy with fat tissue. It's like cooking, you know, how much is too much and how little is too little. You don't want to put too much to cause pressure. You don't want to put too little to doesn't have a function. So you have to judge what's the right amount, and it obliterates the dead space. So even if some CSF escapes in epidural space, it's not going to go further because it keeps the space obliterated. So there is no way to go, because as you know, in the posterior fossa area, spinal cord area, there is CSF leak, which never happens in supratentorial, almost never happens in supratentorial compartment.
Yeah, thank you so much. Sorry, I am a young neurosurgeon from Nigeria. Thank you so much.
Nice to meet you. I was in Abuja about a year ago. Beautiful country.
Okay. Thank you, sir. Thank you.
Thank you, Kenan. I think we'll leave the questions for later. If anybody wants to ask a question, they can ask on the chat, and I'd request Kenan to kindly reply on the chat if possible. We're going to move forward. Sachin,
Thank you very much,
would you
Prof.
like to introduce the next speaker?
Yes. So thank you very much, Prof. As you said, we'll move forward. So our next speaker is the young neurosurgeon speaker, and allow me to introduce him. He is Dr. K.M. Atiq Islam, a young neurosurgeon. I had met him 2 months ago, and he wanted to go and have a training in Fujita with Professor Yoko. So now he's in training at Fujita. And just few days ago, he's been promoted as assistant professor at National Institute of Neuroscience, Dhaka Medical College. And he's going to talk about endoscopic endonasal approaches, beginning of a young neurosurgeon. Thank you very much. So, Dr. Atiqul, you can start your presentation.
Can you see my screen?
Yes, we can see your screen.
Okay, thank you, 𝑑𝒓𝒐𝒇. I am Dr. K.M. Atiq Islam. I am from Bangladesh, and now I am doing a 2-month fellowship under Professor 𝒂𝒏𝒂𝒏 Sensei, and it's a great honor for me to present my work in front of distinguished professors. And I will today talk on endoscopic endonasal approaches, beginning of a young neurosurgeon. And to be a specialized neurosurgeon or any kind of subspecialty, first that is the anatomy. And I believe that every neurosurgeon is confident about the anatomy of his specialty. And for an endoscopic endonasal surgeon, this is also very much needed. These are some pictures taken from Rotan Atlas. Everybody knows this. I will not discuss this more because time is going up. You all are oriented with this image. This is the image we need the most. That is, after drilling of the cellar, we found cellar floor. Then 𝒂𝒑𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂 been visualized in this image very well, and credit goes to again Professor Roton for his brilliant work for the neurosurgeons. And this is the picture we get after drilling. Basically, this is extended approach. And now I will try to share some of my work with you and with my young neurosurgeon surgery colleagues, so that it's an sharing of views and sharing of experience, how we can develop ourselves, how we can step forward, and you can give me suggestion to go to the next level, because I am dedicated in endoscopic skull-based approaches, and I'm working on it for several years. And I will share some of my cases with you. My first case is she was 34 years female and presented with spontaneous CSF leak, with history of headache and with history of neck rigidity and fever. And this is CT cystonogram. You can see that CSF mixed with dye is coming through the sternum canals on left side, and we plan to go to endoscopic intranasal approach. And this is his video. I will show you the short video. This is the cellar part of the surgery. You can appreciate the mucosal coming through the sternum canals, and we are doing drilling to make the opening a little bit wider, because we need to make the surface raw. And you can appreciate the V2 nerve, and at this point we are doing the dural dissection. And after dissection of the dura, we put on LEFAT, then we put on in LEFAT first, then onlay. And for this case, we took 100 flap preoperatively, and 100 flap is placed, and finally we use the fibrin glue. And this is his postoperative condition after 1 month. There was no CSF leak, and she is doing fine. This is my second case. Because I am from a developing country, and most of the tumors come to us like this kind of pictures sometimes. Very giant tumor, invasive pituitary macroadenoma, like this case, where you can see that both carotid is invaded by the tumor, and tumor is going up suprasellar region. And I will show the very short video, final part of the video, to save my time. And as you can see, after removal of the tumor, we can appreciate the pituitary stalk, PCA, optic nerve, optic chiasm, and in this case, we did extended intranasal approach. We drill out the both parachival carotid. We auscultate the both ICA, and after that we went to the tumor part, and this is the end result of the tumor. This is a post-op scan. A small remnant was remaining in bilateral cavernous sinus region, and this is 2 months follow-up of the patient. He is doing fine, and postoperatively he had no CSF leak. And message for my young neurosurgeons colleague that we did extended intranasal opening for this case because of with the target to remove the maximal of the tumor. And for this case, we put a lumbar drain prophylactically for 3 days because the opening was big and there was CSF leak perioperatively, and putting a lumbar drain really helped to manage this case, and he had no complaint of CSF leak. My third case is he's 46-year male, and he presented to us with headache and visual disturbances. And again, you can see the invasive type of tumor. It is eroding the clivus, sala, suprasellar region, and initially thought that it could be a chordoma or kind of invasive pituitary macroadenoma. We choose extended intranasal approach for this case, and this is his operative video. For this case, we took vascularized pedicle flap at the beginning of the surgery, keeping in mind that CSF leak will occur, and it is important for the young neurosurgeons to predict when CSF leak may occur and to take preparation adequately. We usually follow 3 techniques. We sometimes keep the hearted flap, sometimes we keep the rescue flap, and sometimes we do not take any flap. You see, in this case, sella was eroded, and just after opening the dura, tumor was coming, and we removed the bony part on the paraclavicle carotid, and I'm just speaking. The tumor was a little bit vascular, but it was suckable, and tumor removal is going on. For this type of tumor, what we do, we first do removal of the lower part of the tumor, then we go to both sides of the tumor. First, we make a space in the floor of the tumor so that our target is so that the upper part of the tumor descend down, and our principle is not to pull, just continue central decoding, and try to find out the plane. And once we find out the plane, we do sharp dissection, we do gentle ergonomic dissection. An important issue to note for the YNS that you never should pull the tumor. Always be gentle, do central decoding, use sucker, use microcissor, and sometimes thorough washing helps to visualize the tumor margin, and you can do well. And this is the end result of the tumor. We can see the choroid plexus coming through the foramen Monro, intrathalamic adhesion, and aqueduct. And regarding closure of this type of large defect, we put first onlapet, then sometimes bony septum, then onlapet. After putting onlapet, we put some fibrin glue, and then some Surgicel and fibrillar or some kind of gel foam, and then we place the hearted flap. And in this case, also we put a lumbar drain to avoid the CSF leak postoperatively. But some neurosurgeons nowadays comment that there is no need to put a lumbar drain. You can manage it by other techniques. And basically, in last week, I visited Osaka Metropolitan University to Professor Goto Sensei, and he taught me how to give the Osaka knot. I think it will work, and lumbar drain may not be needed in further cases. And this is the post-op MRI, first POD, and this is the patient condition during discharge. He had no CSF leak. And this is my another case. Basically, I am representing one cases from each group. This lady of 30 years presented with all features of Cushing disease, hypertension, and diabetics. Her hormonal profile revealed all features of Cushing disease, and all hormonal profile was done. And in MRI scan, there was no definite tumor, but we can appreciate a small tumor and right inferior part of the pituitary gland, and so we planned for go to surgery. And as usual, this is the cellular part of the tumor. Drilling is going on, and I will like to request my young neurosurgeons that you need to learn the technique of drilling, and drilling really helps. Sometimes you can use kind of dissector, and sometimes you can use upcut to open the sella, but drilling is the best option. So as we thought preoperatively that we may found the tumor at anterior inferior part of the right side of the gland, and practically we found that there is a very small tumor on right and inferior side of the gland that is coming out. You can appreciate. And we took biopsy and removed the tumor. And for this type of functioning adenoma, one thing is very important, that you need to achieve total removal of the tumor. No part of the tumor should kept behind. So after resection of the tumor, we spent a lot of time for thorough check, preserving the anterior pituitary, and we use the angle telescope for final check. And when we are satisfied that there should be no tumor, we finish the surgery. And for this case, we did not took any heart flap because it is a very small opening. And this is her postoperative hormonal status. You can appreciate that her cortisol level and ACTS level is completely controlled. And this is after 3 months of her follow-up. Here, Cushing's phase is gradually improving. Hirsutism is no more, and more interestingly, his hypertension and diabetes is completely controlled. And that really encourages young neurosurgeons like me when we find we can achieve this type of patient. And this is another case. This is basically growth hormone secreting pituitary macroadenoma, as you can see in this picture. This is the macroadenoma, and heart hormone was more than 40. And we choose extended anal approach. And I have skipped the video to save my time. This is postoperative CT scan, first POD. There is no tumor. And postoperative growth hormone level was 0.15 nanogram per ml. And we could achieve complete hormonal remission of the tumor of the patient. And this is after 2 months of the follow-up. Patient is feeling better. His acromegalich phases is gradually improving. And this is another case, 13 years male, who presented to us with no PLPR on left eye, and on left eye it was 6/9. And on MR scan, we can appreciate a stellar suprasellar lesion. It is kind of homogeneously but minimally contrast enhancing lesion. We plan to do again endonasal surgery. We took heart flap first for this patient, and after taking heart flap, we create a common corridor. And for this case, we remove part of the tuberculum stelli also, and both carotid was auscultated. We use Doppler in every cases, and our strategy is we do always forehand technique surgery. We take the help of my assistant surgeon. We work in a team basically, so it really helps. And after adequate opening auscultated of both ICA, we give incision to the dura. In this case, we gave a cruciate incision, and initial part of the tumor was quite suckable with minimum bleeding, and it was basically a meningioma. And our target was to do maximum central decoring of the tumor, and then go to the margin of the tumor to find out the margin of the tumor, so that we can do dissection very meticulously. And for this case, we used CUSA for central decoring of the tumor. And once we identified the margin of the tumor, then we again started arachnoid dissection. Arachnoid dissection is going down, and CUSA is being used for central for decoring of the tumor. I'm going a little faster to save my time. And this is when we reach to the margin of the tumor, we can see the frontal base, and no pool, no traction, just gentle aragonite dissection and use of micro tweezer and decoring going on. At this stage, you can see the both A2, and for this case, we remove a part of the tumor that was on right side because we could not create a plane on the right side, and gross total resection was done for this case. And our closure technique was as usual, multi-layer closure. Inlay fat, boom, onlay fat, then hard flap. And this is his postoperative CT scan, and this is the condition of the young boy during discharge. He had again no CSF leak, and his vision was intact. This is my final case, 60 years female who presented with gradual loss of vision in both eye, and his vision was really threatened, 6/60 bilaterally. And this is his CT scan. This is basically a calcified craniopharyngioma. We choose an endonasal approach, and this is her operative video. We took a small hard flap for this patient. We use angled monopolar to take the hard flap. It sometimes helps to prevent bleeding. Then we make a common corridor. This is the hard flap. Then we started the nasal part. You can see both sphenoidostem, 𝒀𝒏 𝑣𝑚𝑟. At this point, we started drilling. After drilling, again, we are making adequate exposure, drill, sometimes subcut, and dural incision is given just below the falciform ligament. This is the tumor. Basically, in this case, tumor capsule was firmly adherent with the surrounding structures. So we opened the tumor capsule and plan to do again central decoring. In this case, what we do just central decoring by piecemeal fashion, breaking the tumor and bringing out. No traction was given, just break down the tumor and bring it, and gentle dissection. And as usual, we are doing forehand technique. Sometimes assistant neurosurgeons help me by using the sucker. And this is the end result. Gross total removal of done, and tumor capsule was left behind because the patient was little old, and we did not like to invite any comorbidity for this patient. So intentionally, we left some part of the capsule of the tumor. And hard flap with fibrin low. This is the end result of the surgery. Post-op CT scan showing that there is a small remnant, and this is her condition during discharge. And what I should recommend to my young neurosurgeons colleague, that this is an era of very fantastic time of neurosurgery. It's better not to be a general neurosurgeon. Rather, we should focus to be a specialized neurosurgeon. We should focus on a subspecialty, and we need sound anatomy, and we need to work under a good mentor who can taught you the basic tricks and techniques of that specialty, as I am doing, as I have done in several years. And of course, you need to do some cadaver dissection, and I would request my colleagues to build the habit to go to some centers that is recognized worldwide for your subspecialty, and try to improvise yourself every day. Try to learn something every day, because learning is not finished till death. So this is my suggestion for my colleagues, and thank you all for your passion sharing. And this is my country, this is my countryside, which is really very beautiful. And thank you for your passion sharing.
Thank you, Atiq. I think wonderful talk, and it's good for young neurosurgeons to take lead from what Atiq has been doing, going, traveling, seeing people, meeting up, and moving forward. Yes, Kinan, you have a comment.
Dr. Islam, beautiful presentation, and you have a great role models there in your neighborhood. Obviously, Professor Kato and Professor Sharif and all that. You have Professor Pirzad also, I see there. So this is great advice that you gave. Travel, see masters, learn as much as possible, and then early start collecting your cases as you did. Make a presentation, show your results, improve them, and this is the way to go. So I want all of you today, if you forget everything we said, learn from us older, publish. None of the cases is too small to be published. Don't have any hesitation to send your cases to best journals, because you have cases, you have experiences, do good technical kind of equipmenting of this article, and publish, present. All good. I have one concrete, a couple of concrete questions for you. One is, what would, I know you then have huge series, but what is the CSF leak rate, generally speaking? What was your estimate in your cases? I know generally in endoscopic endonasal. I personally do transsphenoidal endoscopic approach but microsurgical resection. Little bit combination of both, and I use fat tissue that I again, same way here, I do it in the form of dumbbell, and through the hole I put the fat tissue, and then when the pressure intracranial wants to push it down, it gets stuck in that foramen. And again, still waiting for the first CSF leak after about 350 transsphenoidal surgeries. I'm still waiting for the first CSF leak with using fat. I think fat is one of the best things to prevent CSF leak. No flaps, no nothing, in my opinion, but it has to be done technically right. It has to be appropriate size, so it gets stuck in that foramen, and no matter how much it pushes intracranially, the CSF cannot come around. My question to you, so, is the CSF problem, if you can elaborate, especially. I never use lumbar drain. Do you use it preventively? Do you use it only when you have CSF leak? So if you can give us a few comments about it. And again, thank you very much for beautiful.
Okay, thank you, Professor, for your inspiring comment. Basically, we use lumbar drain when there is CSF leak during surgery. If no CSF leak, we don't use the lumbar drain. And in all cases of CSF leak, again, we don't use the lumbar drain. When there is, we suspect that there could be, when the opening is wider. When the opening is wider, and we anticipated that in this case, in spite of taking all measures, there could be CSF leak. So in that case, we don't take any chance. We just put a lumbar drain just before reverse of the patient, and we keep it for 3 days, and no CSF leak, we remove it. And we rely on fat. We sometimes do inlay only. Sometimes we follow the gasket seal technique, as you know, and sometimes we follow the yo-yo technique. And I think suturing the sphenoid sinus, sphenoid dura is also very important, as I have learned this And after going to my country, I will try to
Okay, I think we got disconnected. Professor Kato, your comments, please.
So thank you very much for the nice lecture by Dr. Cannon. So just I want to ask one question to Dr. Cannon. So because in Japan, we have many people, the spinal cases done by the orthopedics. So what about the United States? Maybe we can encourage for YNS to do the more spinal surgery, not a bone surgery. So what is your tip? If you have, please let us know.
Yeah, so as you know, maybe you don't know, in the United States, during resident training, residents from first year, it's 7 years is neurosurgery residency in the United States. Residents from the first year start getting involved in all cases, putting screws and doing scoliosis cases, lumbar fusion cases, cervical cases, all kinds of cases, A-lift, T-lift, X-lift, all kinds of lifts. Salman knows better than me. So I think the way to get, and you know, I'm coming from Bosnia and Herzegovina. I did there my first residency. We did lumbar discs there. We did some spinal tumors. Instrumentation, of course, that was 30 years ago, but instrumentation was very, very, very limited. They are doing there as well, because I go there and operate. They're doing more, but I noticed they are not absolutely well trained in spine instrumentation in Bosnia, in Croatia, I mean, there are some excellent spine surgeons, don't get me wrong, but I'm talking about general training of trainees is not that good, and they're not exposed to a variety of cases. How to bridge that gap is only by getting involved, going to centers where they can observe. In the United States, they cannot put screws, but they can scrub in. You know, when I have my fellows, they can scrub in and watch very closely, you know. The other option is for surgeons to come and guest for a month, 7 days, whatever, and do cases with local neurosurgeons. So I think two ways: one, for experienced spine surgeons to come to location and do cases. One is for young neurosurgeons to go to centers where they are doing a spine, because you cannot learn spine from lectures. You cannot learn spinal instrumentation. You can learn some, but not really how to put the screw, how to drill, how to use, and especially now new technology, computers, computer guided, navigation guided. It's a whole science. I mean, it's completely a new thing in neurosurgery. But I think excellent point, Professor Kato. We have to do more, and I hope I will stay involved in World Federation. We have to do more to bring this expertise from countries that do a lot of instrumentation, such as United States, Europe, Pakistan, some big centers, and bring it to whole world, because this is one of the main things we have to do in neurosurgery: bring the spine to everybody, everywhere, every neurosurgery residents to learn this technique. There is no way we can do it without crossing and doing mutual education on both sides. I know, Salman, do you have, I mean, Salman is expert, he travels, he teaches everywhere. Do you have any other recipe or suggestion?
Salman, please.
I totally agree. I think the main thing is teaching. As you know, we have been doing all these cadaver workshops, workshops with pigs, workshops with models, workshops with sawbones, and we have made 3 different kind of workshops. One is just a basic workshop, one is an intermediate, and then there is an advanced. And so we're applying that model in Africa. We're applying that model in Central America, where there's very little spinal surgeons or very little teaching in spinal surgery, and slowly and gradually moving forward. And what we do in the final advanced course, we have everything that a complex spinal surgeon knows. So we start from basic anatomy, physiology, and biomechanics and move forward. I think anatomy was missing huge ways, but I think with COVID, what's happened is a lot of people have got onto it with all these webinars that wonderful people are doing, and I think we have learned loads. The important thing is that, neurosurgeons should take the lead in spine. So like in our hospital, we have a huge center, huge workload, but, orthopedics don't take spine. All spine, all trauma, everything, deformity, everything comes to us. And so we have made that a point, and we've been teaching in big way. And that's what we are trying to replicate worldwide. And hopefully we'll do that. But at the same time, we work with orthopedic surgeons. Now we are starting a fellowship in which a year of neurospine, a year of orthospine, and an exam after that. So I think there are many things we can do with them. They have some additional benefits, and we need to learn from them, and at the same time teach them, because they will be working anyway, because orthopods are so much more than us. So they'll be operating all over the world. So I might as well teach them the technical skills that we need to teach them to keep their patients safe. Yes, Keenan, you were saying something.
Yeah, I wanted to, excellent points, and I really commend. I'm following you what you are doing around the world, and I think you are doing Herculean effort in teach this cadaver courses, low, intermediate, and high. Please continue doing it, and this is beautiful. And I think that's another way to do it. I think what we need to do in neurosurgery is fight for our profession. Okay. We took away, thanks to our forefathers, Dr. Zontag and my partner, Dr. Kevin Foley, and others who pioneered all these techniques, and then your generation, Professor Zileli and many others. So we need to take spine to us, and the more we do spine, when I was starting residency in the United States, orthopeds were doing most of the spine, but then somehow in the 10 years later, we took over. Now we are almost winning or same. Orthopods are welcome to do, but they don't have a good understanding of dura. They are scared of CSF leak. They are scared of cervical spine. Even the most experienced orthopods are not comfortable. They're excellent lumbar thoracic deformities, etc., etc. The other area which we need to conquer, and the United States is completely conquered, is endovascular neurosurgery. In my department, we have five endovascular neurosurgeons. All they do is endovascular and open, mostly endovascular now. But it also belongs to neurosurgery, and I think fighting for these cases and fighting for this part of our subspecialty part is very important.
Okay, thanks. Maybe I ask a Dragan. So maybe you can ask Kenan, please, because you are from Croatia.
Yes, thank you very much, Professor, from the great lecture, and Islam also as the young neurosurgeon. One question for the: do you use for all spine surgery, also in lumbar spine electrophysiology, and in all extradural also, or regarding to the electrophysiology is the question?
I didn't hear, Dragan, was that a question for me or Dr. Sarif?
I think, Kenan, he's asking you, do you use neurophysiology in all cases, extradural and lumbar as well?
Well, first of all, thank you, Dragan, for the question. Dragan was my fellow. He spent with me, what was it, 2 months, Dragan, in Memphis?
Yes, yeah.
And good to see you. And I know that you were now with Professor Kato, and congratulations. I personally don't use for spinal instrumentation, I don't use monitoring. I don't test the screws with any stimulation. I use anatomy. I learned anatomy. I can put screws anywhere with simple X-ray. I don't use much intraoperative navigation, although we have an O-arm. And sometimes when I'm suspicious about something, Salman, I do run the O-arm to check it. Just push the O-arm in the operative room, scan it and check it. But I don't use monitoring regularly unless there is a case that needs it some reason. And by the way, I don't use huge amount of spine. I do a lot of cervical spine, lumbar spine. Occasionally, I do TLIF once, twice a month, but I don't use monitoring very often. What about you, Salman? Do you use it?
No, I think we only use it when we are doing those cases of intramedullary tumors, especially cervical dorsal conus. We also use it when we're doing some atypical screws or something unique, or in deformity, we routinely use it. In patients where we have power more than 3, yes, we use it. With less than 3, we can't really. So, it's like doing old-fashioned way, and many of the things you can get away with it. For example, talking to our friends in US, majority doing even cervical disc monitoring, we have found no evidence that it works, because, or is there any benefit of it? I think it's waste of time, and resources. I think if somebody has got severe myelopathy, severe OPLL, some atypical deformity in cervical spine, must use it. But I think for routine cases, degenerative cases, to use it may not be the best thing. Yes, OYL in dorsal spine, which is very significant. Yes, you could use it, but playing it safe, using microsurgical skills really does the trick in majority of the time. Pirzad, you wanted to have any comments, please? Please unmute yourself.
Yes, Pari. Assalamu alaikum. Good evening, everyone. Thank you very much. Thank you, Professor Salman Sharif and Professor 𝒂𝒏𝒂𝒏. Thank you, Professor Kanan and 𝒂𝒐𝒏𝒂𝒏. Very nice and good presentations. And also we have a lot of spine tumor cases in Afghanistan as well. And we have difficulty with nerve sheath tumors in Afghanistan. And but this extended through the foramen intervertebral, we have some problem for operating and all of the tumor. And sometimes we have recurrence here as well in this like cases. And sometimes the neurological complication is difficult for us because we haven't neuromonitoring during operation. And otherwise the operation and management of spinal cord tumor is a bit good in Afghanistan. And thank you very much for your presentations. And also I saw there's our Afghan neurosurgeon Khalid Zadran, and now he's practicing in Pakistan as well. And I like to say salam as well to him, and thank you, everybody.
If I may just brief comment, salam alaikum. I wanted to tell you that I'm very glad to see flourishing neurosurgery in Afghanistan. After the war in Bosnia, everything was destroyed. There was one big flat land, there was nothing. And then over time, we had new generation of neurosurgeons who build up neurosurgery from the bottom up. Dr. Omer Hodges, Dr. Burazer, and many others, you know them. And they are very, very productive. So I'm glad to see you leading this and keep doing the good job. If we can do anything to help you, I'm at your disposition.
Thank you very much. Thank you. You are very kind. Yes, we have, as you mentioned, now in this time also we are facing, we have a lot of neurotrauma cases as well, and especially war wounded patients. And beside this, we have also brain tumor and spinal cord tumor as well. And we are facing with limited resources, and also we need also some trainings as well. And we are communicating, and like to say thank you for Professor Kato, that supporting Afghanistan to the supporting neurosurgery, and also Pakistan Society of Neurosurgery as well. Thank you.
Okay, thank you very much. Professor Kato, would you like to say last few words, please?
Okay, so before me, maybe the Dilshot, you want to ask just a very short question, Dilshot?
Thank you so much, dear lecturers, Professor Kenan Arnavutoglu and all other professors, and our friend Atiqul Islam, also very nice presentations and reports for today's presentation. I have a question for Professor Arnavutoglu. A simple question. Do you use any kind of first scene guided imaging for intrinsic spinal cord tumors, or you just follow the anatomy, the lines, geometry of the spinal cord?
I personally don't use any guidance other than ultrasound and X-rays, and of course intraoperative monitoring. So these are my anatomy, and these 2-3 tools that I use, they are my tools. But I'm
armamentarium. Thank you so much.
I have only one more question, Dr. Wozniak. Are you with us?
Yes. Yes, hello. Can you hear
just want to...
Can you hear me? Can you see me?
Yeah, we can see. I just want to greet you.
Yes.
And please stay safe. And I know what you are going through, and our prayers, and we are with you 100%. Okay.
Thank you. Thank you. Thank you. Finally, I have internet connection because I have crossed the board. It's some abandoned area. I had no connection at all. Now, fortunately, I could hear. Can I give some comments also? Because I had no chance before.
Sure.
First of all, about the training of young neurosurgeon, I am absolutely not agree that the young surgeon must be focused on something specific. They must do everything. They must train the feeling in fingertips, especially for endoscopic neurosurgeon. It's very important. Why? Because you work with endoscope. You have a two-dimensional vision, two-dimensional picture, and this feeling of tissues transferred via your instrument to your fingertips. The feedback from tissues helps very much, and this is very important. That is why I recommend to youngest do everything what they can from the beginning, and then they will be specialized in that. So it's my opinion, it's my way, but actually I started as a general. I was for 4 years as a general surgeon, then went to a neurosurgeon. And Professor Arnavutoglu, thank you very much for excellent lecture. I could hear it's almost to the end. Excellent surgery, excellent, very smart and accurate surgery. And hope to see you in person in future. So thank you. Thank you.
Good to see you, Wozniak. It was wonderful talking to you and seeing you here.
Thank you.
And hopefully we can help you with various things in future as well.
Yes, thank you. Thank you that I left you for a while.
So someone, one more, the question from, you want to ask something, Doctor? Dr.
Zadran, you want to ask any question?
Yes, sir. Assalamu alaikum. And I'm so glad that Professor Kenan explained extremely good cases. I was feeling like I'm standing inside the surgery, and I learned a lot as a young neurosurgeon, and I convey my regards to Professor Salman Sharif, our respected honorable teacher, and 𝒂𝒏𝒂𝒏 and the president of 𝑦𝒂𝒂𝒏. And sir, I want to ask one question from Professor Kenan, and the question is that in one of the cases in surgery, while you are operating on a tumor in the spine, I've seen that you have taken the take-up suture before opening the dura. Sir, I have never seen this technique. Can you explain it, please?
Thank you very much. By the way, where are you from, Dr. Zadran?
Sir, I'm basically from Afghanistan. I'm the first fellow of the College of Physicians and Surgeons of Pakistan in neurosurgery. And recently, I'm doing my post-fellowship training here in Ahmedabad in endoscopic surgeon. And that's it, sir.
So,
sorry, Kenan, I apologize. I just need to go. I have to give a lecture in the WFNS Spine Committee webinar elsewhere.
Okay.
So
Thank you
I'm
so
sorry, I'm going to take the leave, and it was wonderful seeing you all, and Yoko, as always,
Okay, thanks so
Kenan,
much.
our friends from all over, especially Afghanistan. It's wonderful to see you all, and thank you. I'll take leave. Thank you very much.
Thank
Bye-bye.
you. Yeah, thanks so much.
All the best.
Thank you very much.
I'll answer this question before we adjourn. Beautiful webinar, by the way, took us to, but the interest is very, very high, and that's great. Professor Kato, what you are doing is tremendous. The stitches, I put 2 tuck-ups whenever I open the dura, anywhere in the brain, everywhere. Sometimes I do always with my residents, and residents sometimes don't have good feeling. So, and I always let them do a lot of the case, and if they are senior, they do all the case. But when I put tuck-up stitches and elevate the dura, I get 1 or 2 millimeters separation from the pia in the brain or spine. And that is the reason why I do this tuck-up technique, where then I do the incision of the dura with elevated the dura. So I always do it, and that prevents violation of the pia by the knife. I see Dr. Sachin nodding. You use the similar technique, or?
Yeah, I use similar techniques. Yes.
Sachin?
Yes. So thank you very much. So I use a similar technique, especially when you have a tumor below and you want to open the dura without disturbing the arachnoid. It's one of the very useful technique, that you lift the dura up, so you sort of create some dead space between the arachnoid and the dura. So thank you very much. So it was a wonderful webinar today, and I have 2 announcements to make before we close. One is about our next webinar. We conduct this education webinar on every 2nd and 4th Sunday, and today was the 4th Sunday of this month. So our next webinar will be on the 2nd Sunday of June. That falls on the 11th of June. And it'll be at the same time with some interesting topic and interesting faculty. So please count on this webinars and share the information with all other young neurosurgeons, so they can also benefit from this education activity. And about our next conference, we have World Young Neurosurgeon Congress, 2nd World Young Neurosurgeon Congress, which will be in Indonesia. It will start on 29th of July till August 1st. And I request all the young neurosurgeons to send their abstract. We have a dedicated young neurosurgeon session there, and there'll be many hands-on activities of different specialties. So definitely it will be a feast for the young neurosurgeons. So please count on this conference. And one more announcement, I would request Dr. Dilshad to please make announcement about the Central Asia Conference. Dr. Dilshad, are you there?
Yes, I'm here. So using this opportunity to have you all here, there are many participants from Bosnia, Germany, and other Asian countries. I would like to announce we are organizing a Central Asian Congress, which is conjoined with 7th International Minimal Invasive Neurosurgery Congress, which is also chaired by Professor Yoko Kato. So this is a kind of congregation of all Central Asian countries conference, and conjoined with Minimal Invasive Conference, which is going to be in our country, in Uzbekistan, capital city Tashkent, on 15th, 16th, and 17th of September. We invite you all to be active and participate in our Congress, which is going to be both online and offline, which is hybrid format. So you can send your abstracts, and there is already Congress website is ready. So you can send your abstracts and submit it. So we wait you all in our country. We welcome everybody to participate. Thank you.
Thank you, Dr. Dilshad. So before we close, I would request Professor 𝒀𝒑𝒂𝒏 to say a few closing remarks, and then we'll conclude the webinar.
Well, thank you very much, Professor Cannon. Of course, he's a very good neurosurgeon, but also he is a great educator. He always thinking about the YNS. I think maybe that he can be one of the good job of the 𝑤𝑪 in future. I think he will be thinking more the YNS. I think I really appreciate your lecture today. It was the excellent one. And also Dr. Pawat and also the Alexander, thank you very much for as a commentator or discussant. And also, I really appreciate all of the participants. You are very lucky. Today's webinar was so nice. And also the Dr. Atik, that he went to the Osaka tonight, and the way back from Osaka to the Tokyo, he joined the cadaver dissection course in Tokyo. Then he came back today. So that means is that he is really lucky to come to our place, I think. Thank you very much for your joining today.
Thank you very much. So I conclude that today's webinar is over. Thank you very much. Arigatou gozaimasu.
Arigatou.